Hi, this is Vic Calland again. What I want to talk to today is about pneumothorax, tension pneumothorax. It's a condition that is very badly taught. A lot of people tell half-truths and, in fact, complete fiction about the condition. A simple pneumothorax generally doesn't cause very much distress to someone, provided they've got reasonable pulmonary function. And it's the sort of person who turns up into the GP's surgery and they can sit comfortably and you can examine them. And yes, you will discover that there is reduced air entry, never absent breath sounds, but reduced air entry on that side. The reason why you don't get absent breath sounds is that some sound is transmitted over from the other side. You will also, in the quiet of your surgery, be able to hear hyperresonance, and you will be able to see inequality of chest movement because they will lie on the couch and you will look at them from the feet on down the bed and you will see that inequality. That's taught to pre-hospital care practitioners when they come to do their immediate care courses, pre-hospital emergency care courses. But you know that patients are not like that. You will be dealing with someone, possibly in an upside down car on a motorway in the middle of the night with rain bucketing down around you and the fire crew with all their pumps and generators going. It's a little bit more difficult in those situations. So, what are you likely to find? Well, frankly, there are two completely different types of tension pneumothorax. There are the ones that are spontaneously ventilating, and there are the ones who are ventilating. And as soon as you start to apply any positive pressure to the airway, in someone who's injured, you are substantially increasing the risk of a pneumothorax. But, okay, the guy who has been injured and he is developing a pneumothorax, tension pneumothorax, if they're conscious, they will have chest pain. They will certainly have a degree of respiratory distress. So that's universal. Common findings that you'll find in at least half to 3/4 of the cases is that they will have a rapid heart rate. Great, they've just been in an accident, they've probably got other trauma as well. They could have a fractured pelvis, they could be hypovolemic, so tachycardia really isn't much use to you. They may have decreased air entry, or at least let's say they will have decreased air entry on the affected side, but you may not hear it because of all the ambient noise around. In less than 1/4 of the cases, you will find that there is a low oxygen saturation. You might find that there is tracheal deviation, but that tends to be limited to people who have been ventilated, and you will find hypotension, but there again you've got a patient with multiple trauma, so you would expect them to be shocked. What do you find in less than 10% of cases? Less than 1 in 10 will you find cyanosis, hyperresonance, and you probably won't discover a decreasing level of consciousness until they actually collapse on you because they've got no cardiac output. So, how do you identify it? Well, frankly, you need a very high index of suspicion. It is easy to miss. The main thing is the patient who is beginning to deteriorate. It is the rate at which they deteriorate that determines your actions, and the first thing you should be thinking about is, are they developing a tension pneumothorax? Because that is something that you can treat. I'm putting up now a press cutting of a coroner's inquest on a woman who died on Blackpool Beach when she was hit by a sand yacht. And as you can see, her husband actually described very, very accurately what was happening. I thought she was just having a little bit of a problem breathing, but it turns out her lungs were collapsing. Her eyes just looked straight ahead. She didn't blink or anything, and her stomach was going up and down really rapidly, but there didn't seem to be any air coming out of her mouth. It is that failure to move air. I have seen people, and it looks like they're having a panic attack. It's difficult to spot. Now, if you're ventilating someone, obviously you can make the situation profoundly worse, because whilst people can only inflate their lungs with the kind of pressures that they can exert, you can actually create up to 30 centimetres pressure of water by using a bag valve mask. And one of the signs to look for as an immediate care practitioner is that whoever's ventilating your patient, and it's probably going to be the technician, the least qualified person of the team using a BVM, they will begin to adjust the airway, apply a bit more jaw thrust, adjust the seal of the mask, possibly insert a Goodell, possibly insert an NP. What they are discovering is that when they're ventilating, they're not seeing any chest movement. They think they're failing. In fact, no, it's the patient that's failing. But not having the insight into being able to diagnose attention pneumothorax, they are looking at their failure. And so they keep on adjusting what they're doing. If you see an ambulance technician doing that, or a nurse doing that with a patient, then what you need to do is immediately assess the chest again. If you are in any doubt whatsoever, do a needle thoracentesis. And that's going to be the basis of my second talk on this subject, because what we're taught on how to do it is generally a load of nonsense. So, first session that I covered was on the 5 H's and the 5 T's, and how you have to diagnose something like attention pneumothorax really quickly. This one is just how difficult it is to diagnose. And the next one is what you need to do if you're going to successfully treat it. All brought to you thanks to Patronus Rescue International, which is not only a training organisation, but we also supply medics to remote areas and other services to do with emergency medicine and pre-hospital care as well. Have a look at our website and do like us on Facebook if you think this has been worthwhile listening to. Thank you.